And I'll now request Dr. Ajay Sharma sir, who's chairman of the IQ group and a wonderful cataract and refractive surgeon, to go ahead with his talk on. He's going to be speaking to us on OOPS moments in refractive lens exchange surgery. So please go ahead, sir.
Good afternoon, everyone, and thank you, Gaurav, for the introduction. Uh, we all know that today the cataract surgery as such is a refractive surgery because we want to have a perfect results post-operatively. But there are certain moments, certain patients where we do a refractive surgery only when even the patient doesn't have much of a cataract. So historically, the thing started way back in 1776, and first systematically performed RLE was in 1890 by Vincent, and then with the introduction of the lenses, the things became very easy. Now, refractive surgery, as I said, is associated with the lens opacities, refractive errors and lens opacities, especially in presbyopic age, especially high myopes, more than 10 diopters, high probes, more than 5, and patients more than 40 years of age, they are the perfect, the presbyopic and high probes are the perfect. Advantage is just the same surgery as we all do, the cataract surgeries, and disadvantage it's a intraocular procedure and chance of retinal complications are more in myopes. And preoperatively on, we have to do the same workup and all what we do. It can be done in myopia, hypermetropia, astigmatism, and amblyopias, but in myopia, when we have to take in certain contraindications, which you see here, that there should not be more of the retinal complication like peripheral lattice degenerations, young eyes with no posterior vitreous detachments, and presbyopic eye with macular degenerations and all. And these can be the complications, because this is before having a OOPS moment, we should know what all can happen during the surgery. So retinal detachment is the most dreaded one, and definitely when it happens, it is mostly post-surgery, and it has to be dealt by our retina colleagues. And then there can be a macular degeneration, edemas, and all those things. Similarly, in hyperopia, we do these surgeries, but we have to take care because there is a small hyperopic eyes and shallow ACs are there, and they are more predisposed to close angle glaucoma. And this can be complications, can be PCOs, which are more in hyperops and secondary post-op IOP rays. And it can happen in children, astigmatism and all. Now, this is something which we all should know. Special consideration is in high myopes, we know there is a depth and stability of the anterior chamber is abnormal, so which necessitate the use of dispersive viscoelastins. And eyes with excessive axial length, there is risk of perforation and choroidal effusion in hyperopic eyes. So just to show just a normal refractive lens exchange, it is just like a normal surgery. This is a post-femto case, and removal of the nucleus should be done very nicely, and low phaco power modes are very important here. Because if you see here, it is just only the vacuum which we are creating, and with that vacuum, we can take out the nucleus. But you have to be very careful, because even at low vacuums, you have chances of rupture of the posterior capsule if you are not proper again in managing or handling that. And then we take out the cortex, and implantation of the lens as such is there. Certain things which can happen is, one most common is when if the pupil is constructing, there can be a small pupil, and with these lenses which have four closed haptic design lenses, though it can become very difficult. So see here the lenses, I'm not able to push the lens inside. I tried maneuvering it inside, but then we did a bit of a dilatation, and after we dial the lens, after a dilatation of the is done with the mydriatic, so we can see the lens going inside. The one haptic goes inside, and this one goes inside, and then the second haptic goes inside. Now that is done, but at the end still you need to check. So I am rechecking it with the second instrument whether the haptics are inside or not. This is the PC rent. Now this is the most dangerous thing which we will encounter, especially in refractive lens exchange. Patients are young. Now I have done everything, implanted the lens, but when I am doing the IA, I just found now this. What is this? This is the capsule I have got here, and this is, I never realized that there has been a rent, and so now we have to manage. Now this is a patient where I have implanted a pure C, which is a toric lens, and I have to keep it in this direction. So dilated again with the intracameral phenocane, and now I have to take the lens out because it was going down from the place where it was, and now so I took it out, kept it in the AC, and then I am tucking the two haptics. I didn't have any choice, but I have to put it in the sulcus, though it is a single piece lens, not advisable, but still this is what I did. And but again, and I have to keep it at an angle where, because it's a toric lens. So after that, and fortunately it was there and there was no problem. Later on, patient had a good 6/9 vision next morning, and after 15 days the patient is doing wonderfully well. But definitely we have to keep a track. Now this is something on a subluxated lenses. You can see this is a catalyst machine. We can see the surface mapping, and here you can see the dislocation, clear cut dislocation here. Now we have to be very careful while we are operating, and here we have just cut the lens into 4-5 fragments, and then we are taking the capsule. We are doing a very good hydro because, and rotating the nucleus inside, because that is needed. And once that is done, again with a very slow vacuum, the nucleus is taken out. You see there is no movement of the tip of the phaco, and you can see how nicely this has been taken. Now this is something, and we have to put the CTR, and then the lens was put inside, and the patient is doing very well. Now this is something very interesting. This is post ICL refractive lens exchange, because most of the patients now which got the ICL done, now this we tried with the femto, and we saw the surface mapping, we could get the anterior surface, but again the posterior and even all this was not there. So we need to do it manually, and which can be done in a catalyst. And here we are doing the things manually. Just the last one, and we did it manually, and it was nicely maneuvered. You can see the ICL here, and in second case we just tried the femto, and immediately it took over, and then we just did the surgery here, took out the lens, and a routine phaco surgery was done. And again you can see how nicely just with the vacuum we are doing the phaco surgery. I think we can stop it here. Thank you very much.
Thank you, Dr. Ajay. Before Gaurav starts his talk, I just wanted to ask you, like, in a refractive lens, may not be ready for a need of, often they may want great distance, intermediate and near, and you end up putting a trifocal. Would you think of doing a mix and match, giving one kind of lens for one eye, or would you do a micro monovision in these young guys? How would you deal with it? Would you do either of one eye and do a micro monovision?
So I think as I said, the counseling part is again very important, telling the patient about each and everything. And trifocal lenses with the halos and glare, these patients are young patients and most active life, and so they don't probably want to go for those lenses. EDOFs are the best for them, and especially the refractive one, the Pure C, which has come in as a boon for such patients. So I'll prefer that, and mix of micro monovision definitely can be done.